everybody, and welcome to today's Research Connect series. My name is Alexandra. I'm a patient partner with the CDTRP, and I'll be facilitating today's webinar. I am a preemptive kidney transplant recipient from 2017, and I really am very excited, in particular, about the topic of today's webinar as a kidney transplant recipient and as somebody who spends a lot of my time, helping patients to break down barriers that are potentially standing in the way of them receiving a kidney transplant. I've had my kidney transplant for 7 years now. I've had 2 healthy children post-transplant, and I really attribute having a transplant before I needed dialysis to having the support and learning of somebody with lived experience in my corner. And that was my mom, who had a kidney transplant 7 years before mine. She helped me to understand the impact of being informed and knowing the right questions to ask to achieve the best possible outcome, which we know is a preemptive living donor kidney transplant. I'm a firm believer that being informed and knowing the answers you need is so important, because many times patients don't know the right questions to ask. And so that's why my work as the program coordinator, provincial program coordinator of the Transplant Ambassador Program is so meaningful to me. We have 200 volunteers across the province who are all either kidney transplant recipients or living kidney donors who are here to support current patients and potential living donors through the process. You can find out more at transplantambassadors.ca. I also work closely with the Kidney Patient and Donor Alliance of Canada on their advisory board, and deeply involved in our first advocacy campaign, which is the Transplant First Advocacy Campaign. And you can learn more about that at transplantfirst.ca. So that's about me. I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous people, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many other, whose histories, languages, and cultures continue to influence our vibrant community. I encourage you to write your own land acknowledgement if you have one in the chat box now. We would also like to acknowledge AstraZeneca and CIHR, whose generous support we could not have had to host these sessions without. Before we dive into the content, I'll pass it to Erica for some general CDTRP notes.
Thank you, Alexandra. Today I have one announcement for everyone, and it's a save the date for our PFD forum. This year's Patient, Family, and Donor Research Forum will be held virtually on June 13th and 14th. Registration will be free and can be done through our website. The link to register will soon be live, so keep your eyes out for that. Thank you.
Thanks, Erica. So before I introduce the speakers, just a few housekeeping notes. Today's session is recorded and posted on CDTRP's website and YouTube channel. During the presentation, please keep your mics off. If you have a question or comment, you can raise your hand with the raise hand button or type it in the comment section. I'm very pleased, personally and professionally, to introduce our speakers, who are Dr. Garg, Amit Garg, and Seychelle Yohanna. Dr. Garg is world-renowned nephrologist and clinician-scientist. He's a professor with the Departments of Medicine, Epidemiology, and Biostatistics, and holds the endowed Dr. Adam Linton Chair in Kidney Health Analytics at Schulich Medicine and Dentistry. His research is focused on improving health outcomes for patients with kidney disease, from early diagnosis to treatment. I'm a little biased because he also cared for me in London during my transplant workup and transplant in 2017. Dr. Seychelle Yohanna is an assistant professor in the Department of Medicine at McMaster University. She's a transplant nephrologist at St. Joe's Healthcare Hamilton. Her academic focus is improving access to kidney transplantation and living kidney donation for patients in Ontario with CKD, chronic kidney disease. She's particularly interested in removing system barriers to living kidney donation and leads the Hamilton One Day Living Kidney Donor Assessment Clinic. We're so excited to have you, and I'll hand it over to you now.
Thank you so much, Alexandra. And it's a real pleasure to be presenting this session with Dr. Yohanna, and also in the audience on the call are several people who are involved in this project. To be efficient, we thought we would present this trial that we did, improving access to kidney transplantation and living donation. I'll start with a video and then I'll be turning it over to Dr. Yohanna for further insights. During the question period, again, many people on this call were intimately involved with this project, and so there might be opportunity to hear from them as well. So let me share my screen here, and here we go.
My name is Amit Garg. On behalf of the Enhanced Access to Kidney Transplantation and Living Kidney Donation investigators, thank you for listening to this talk on the effect of a multi-component intervention to improve patient access to kidney transplant and living kidney donation, a pragmatic cluster randomized trial. This trial was made possible by several organizations. Full results were published online November 3rd, 2023 in JAMA Internal Medicine to coincide with a late-breaking clinical trial presentation at the American Society of Nephrology meeting in Philadelphia. In the journal, there's also a nice commentary from Dr. Ebony Boulware, the Dean of the School of Medicine at Wake Forest University. The results are also discussed in a freely filtered podcast with guest Sue McKenzie, a kidney transplant recipient and founder of the patient support program used in this trial. I declare Astellas Canada provided support to produce education materials used in this trial. Declarations from other co-authors are in the paper. In terms of the rationale of this trial, we have a serious problem in kidney care. Patients with advanced chronic kidney disease have the best chance for a longer and healthier life if they receive a kidney transplant. And every 100 kidney transplants save the healthcare system in Canadian dollars $20 million over 5 years, primarily from averted dialysis costs. And yet, due to many barriers, many eligible patients today will never receive a transplant. Leaders in the province of Ontario, Canada, decided to address this problem. For context, in Ontario, advanced CKD care is provided by 26 renal programs managed by a government-funded provincial renal agency. Together, these programs treat 24,000 patients each year approaching the need for dialysis or receiving dialysis. Care is provided by over 3,600 nurses and nephrologists, and half of patients are transplant eligible. About 725 kidney transplants are done each year across 6 transplant centers, with 30% of kidneys coming from living donors. And prior to 2017, improving access to transplant was not a priority for the renal agency. Using a process described in the paper, a multi-component intervention was co-designed by a broad group of stakeholders to address several barriers which prevent kidney transplantation and living donation. These components were administrative support from a central operations group, for each program to establish a local quality improvement team to drive local performance and share best practices with other teams in monthly provincial rounds. Educational resources for health professionals, patients, and potential donors. Several were curated for use. And one resource, Explore Transplant Ontario, was created and mass-produced. A patient support group called the Transplant Ambassador Program, where past recipients and living donors voluntarily spent time in renal programs to share experiences and provide hope. And reports, which showed programs how their patients were completing different steps towards receiving a transplant, which were also discussed annually in one-on-one performance meetings between program leaders and the provincial renal agency. Leaders also agreed to generate robust estimates of the intervention effect in this pragmatic cluster randomized trial to determine if renal program-wide use of this multi-component intervention is superior to usual care in helping eligible patients complete up to 4 key steps towards receiving a kidney transplant. These 4 key steps statistically analyzed in a multi-state model were 1. Referral to a transplant center for evaluation, which in Ontario is done by a renal program after they complete required pre-evaluation testing. 2. Having a person contact a transplant center to begin living kidney donor evaluation, where patients with multiple potential donors only had the first one counted. 3. Being added to the deceased donor waitlist. And 4. Receiving a transplant from a deceased or living donor. In terms of the trial design, both the protocol and statistical analysis plan were published before outcome analysis. It was implemented as a part of a learning healthcare system. There were no research coordinators at the 26 programs. It was published with patients and healthcare administrators as full partners, and it generated high-quality information at a fraction of the cost of a usual trial. It was registry-based, where baseline and outcome data came from healthcare databases. It used covariate-constrained randomization to allocate 13 of the 26 programs to each of the 2 groups. And it was approved by the Research Ethics Board to use waived patient consent, which meant all eligible patients who received care in the 26 programs entered the trial. To enter the trial, patients were aged 18 to 75 with no recorded contraindication receiving a transplant in our data sources, such as no evidence of home oxygen use, living in a long-term care facility, select cancers, or very high comorbidity. Patients approaching the need for dialysis received care in specialized clinics and had persistent evidence of an eGFR less than 15 or a greater than 25% 2-year predicted chance of receiving renal replacement therapy. Remaining patients entered the trial after receiving outpatient maintenance dialysis, either in a center or at home. And during the 4.2-year trial period, about 10,000 patients entered the trial in each of the 2 groups for a total of 20,000 patients, where half were approaching a need for dialysis. The analysis used an intention to treat approach. Involved 1% of patients emigrated from the province, 1% recovered kidney function, 14% became ineligible to receive a transplant, and 17% died. These rates were similar between the 2 groups. Patients rarely crossed over between the 2 groups. In other words, patients spent 97% of all follow-up time receiving care in a program per the random allocation. And of interest, for the group approaching dialysis, 48% started dialysis during the trial period at a rate that was similar between the 2 groups. As shown in the paper, the 2 groups were well balanced on over 50 program level and patient level baseline characteristics. The mean age was 61, 38% were women. For those who entered the trial approaching a need for dialysis, the median eGFR was 16, and the median random urine albumin to creatinine ratio in milligrams per millimole was 162. And 1% of patients had a history of a prior kidney transplant. We observed evidence of intervention uptake. Each of the 13 programs established a local quality improvement team, developed a charter with their goals and activities, met regularly, and participated in monthly provincial rounds. Together, the programs reported over 1,700 patients completed Explore Transplant Ontario. The transplant ambassadors recorded meaningful interactions with over 5,000 patients with advanced CKD and 700 potential living donors. And each of the 13 programs received reports and met annually with the Provincial Renal Agency to review performance. As described in the paper, we observed no evidence of potential contamination bias, meaning programs in the usual care group did not inadvertently gain access to intervention materials. So here are the main results. Here we have the 4.2-year trial period in calendar months, and through this animation the counter will move right in time. We have the number of steps completed, standardized per 10,000 patients in each group who entered the trial, where the 4 steps again were referral, donor evaluation, waitlist, and transplant. We had the 2 groups. Patients entered the trial throughout the trial period, and after entry, they were followed for a median of 2.1 years. The start of the pandemic, 2.4 years into the trial period, substantially impacted intervention delivery for at least a year. Quality improvement teams met less often, provincial rounds were paused, healthcare staff retired or were redeployed, and transplant ambassadors transitioned from in-person to virtual meetings. Referrals, donor evaluations, and transplants throughout the province were also delayed at this time. And so the trial began, and this is what we observed. There was no significant difference between the 2 groups in the rate of completed steps, with an adjusted hazard ratio of 1.0. Numerically, there was a higher rate of donor evaluations in the intervention group, with an adjusted hazard ratio of 1.22. However, the 95% confidence interval of this ratio contained a value of 1. As shown in the paper, we did not detect a significant difference between the 2 groups in different steps examined in isolation or in combination, in different subgroups, or in the rate of living donor transplants. The proportion of patients who completed at least 1 step, at least 2 steps, at least 3 steps, and 4 steps during the trial period did not differ between the 2 groups. So in conclusion, acknowledging the pandemic negatively affected intervention delivery, we failed to show this intervention increased access to kidney transplantation and living donation, which was disappointing. However, we are not giving up. We and others are deeply committed to addressing this complex and important problem. After much introspection, we believe aspects of our approach remain sensible. Co-designing solutions with diverse stakeholders, connecting health professionals in a community of leading practice, delivering patient and health professional education multiple times and in multiple formats, empowering past recipients and donors to share positive experiences with others, monitoring and reporting key steps towards receiving a transplant, and evaluating intervention effects robustly in a learning healthcare system. And so we are now completing a process evaluation to optimize our future approach, and some early data suggests better integration of different aspects, more healthcare resources for intervention delivery, better retraining for personnel who turnover, and making it clearer who is accountable for what may lead to future success. And so on behalf of the ENACT LKD investigators, thank you for listening.
Okay, so maybe Dr. Yohanna, I'll turn it over to you.
Sure, thanks, Emmett. I'll go ahead and share screen. All right, can everybody see my screen? I've lost all of you.
No, we can't.
No, okay. Sorry. That's because I didn't share it. Okay, hold on now. Now can
That's
you
great.
see it?
Yep.
Okay, perfect. So thanks, Emmett. So today I'm going to be presenting to you all the results of the ENACT LKD process evaluation that Dr. Garg just alluded to at the end of his video. So we conducted a process evaluation alongside the ENACT LKD trial, and our objectives of this process evaluation were to understand whether the intervention was implemented as we intended it to, and whether the intervention addressed barriers to transplant that we wanted it to address, that we intended to address. And in the second aim of this process evaluation, we were trying to understand potentially the mechanism of change. So the evaluation included surveys to all 27 CKD programs in both the intervention and usual care groups. We also conducted interviews with the QI team leads in the 13 intervention group programs, and the evaluation was informed by 2 implementation science theories of behavior change in healthcare that I will describe in a few slides. And so we published the protocol for the process evaluation, and this was all done in advance of knowing any of the results of the main trial that was just presented. So as I mentioned, there were 2 implementation science principles that were embedded throughout the process evaluation. So for our first aim, where we were trying to assess the implementation of the ENACT LKD intervention, the first theoretical principle that we use is something called normalization process theory. And this is a framework for understanding the work that people do to implement and embed interventions into routine practice. And so MPT focuses more on sort of what people actually do rather than what they believe or intend. And there are 4 constructs that are central to the workability and integration of interventions into routine practice. The first is called coherence. And that means, what do those involved do to make sense of the intervention? The second is cognitive participation, which is how much are those involved engaged with the intervention. The third is collective action. So how much effort do all those involved put into the intervention? And the last is reflexive monitoring. So how do those involved track how they were doing with respect to implementing the intervention? And so normalization process theory provides insight into potential barriers and enablers to the integration of a complex intervention like ENACT LKD into routine healthcare. So that was the first theoretical framework that was used, part of assessing implementation. So there were sort of 4 components to assessing how the intervention was implemented. The first was quantitative analysis. So within the surveys, there were questions that quantitatively assessed how well many of the materials or components were used in the intervention group programs. The second part of assessing implementation was using normalization process theory. There's a measurement tool, it's called the NOMAD instrument. And we embedded this NOMAD instrument within the surveys to the intervention group programs to understand how the intervention was implemented. The third part of assessing the implementation was using interviews with QI team leads. And the interview guide had normalization process theory embedded questions within the interview guide. And the final part of assessing implementation was conducting a document review. And so this really was, there were several components to this intervention, and it required organizations to provide certain things like, holding monthly collaborative calls, collecting team charters from the quality improvement teams and reviewing those charters and so forth. So we conducted a document review to assess how well we implemented the strategy as planned. The second theoretical framework that was embedded within our process evaluation is called the theoretical domains framework. And this helped us to potentially understand the mechanism of change. So we were asking the question, did the intervention as it was delivered address the barriers that it intended to address? And so here, the theoretical domains framework has 14 domains that can be used as categories of barriers and enablers that can be targeted by an intervention to assess whether the intervention affected those barriers as it was designed. And these domains are things like knowledge, beliefs, social influences. So we assess perceived barriers and enablers to transplant from the perspective of the healthcare provider. And we chose the barriers, we asked the questions about barriers and enablers based on what we felt were targeted by the intervention. So that were related to the 4 components of QI teams, administrative support, education, peer support, and data. We asked healthcare providers to rate their level of agreement with barriers to transplant from their perspective at the provider level, the CKD program level, the patient and living donor level. So an example of a question would have been, you know, to rate how much you agree with this statement. I'm not confident in my ability to promote kidney transplantation and living kidney donation. So that's one example of a barrier they may have they were asked to rate. So in terms of the design of the survey, in the intervention group and the usual care group, all 27 programs received a survey, but it was slightly different whether you were in the intervention group compared to usual care. So we targeted 6 healthcare providers from each of the CKD programs in each arm. And these could be dialysis nurses, CKD clinic nurses, nephrologists, and in the intervention group, the QI team leads. So in the intervention group survey, we included questions from the NOMAD instrument, which helps us to understand how a new intervention or this new practice is implemented in routine care. We included fidelity measures, so quantitative measures of, you know, how often a resource was used, for example. And then we conducted an assessment of barriers that was informed by the theoretical domains framework. The usual care surveys was again the assessment of barriers because we were going to compare them in the intervention and usual care group. And we also included a few questions about contamination just to assess whether the usual care group engaged with any of the intervention activities, such as you know, creating a new peer support program or creating a new QI team dedicated to increasing access to transplant. So a little bit about the interviews. We conducted one-on-one semi-structured interviews with each quality improvement team lead and one other healthcare professional with an aim of completing 26 interviews. The questions within the interviews were informed by normalization process theory, but also included open-ended questions. And we particularly asked about how what their experience was in delivering the intervention and also the effect of the COVID-19 pandemic. And finally, what barriers or enablers they encountered during the implementation. And these interviews were analyzed qualitatively, and we developed themes. So in terms of the results of our evaluation, we had 114 healthcare professionals across all 27 programs complete the online survey, which was a 70% response rate. In the intervention group, 53 out of 78, so nearly 70% of healthcare professionals in the intervention group, of invited healthcare professionals in the intervention group completed the survey. And this represented 11 out of the 13 programs, with a range of 2 to 7 respondents per program. In the usual care group, 61 out of 84, or 72% of invited healthcare professionals in usual care completed the survey. And this represented 13 out of 14 programs with a range of 1 to 6 respondents per program. For the interviews, 17 out of 26, or 65% of invited healthcare professionals in the intervention group participated in interviews. And this represented 11 out of the 13 programs, which is the same as those who completed the survey. What we know about those who completed the survey in the intervention group is that they were experienced healthcare providers who had worked an average of at least 13 years. So within the survey, in terms of assessing how the intervention was implemented, I mentioned that we used this normalization measurement tool, or the NOMAD tool. So when assessing key factors that lead to the successful implementation of an intervention, participants were neutral about the work that was required to understand who was responsible for different aspects of the implementation process and the work needed to evaluate success. But overall, the overall normalization scores were actually quite good. So there were 3 things that were found. The first is that participants were relatively familiar with the intervention. There was a mean score of familiarity of 7.1 out of 10, with 10 indicating that they were very knowledgeable about the intervention. Most participants felt that the intervention was currently a regular part of their work, with a score of 6.9 out of 10, with 10 indicating completely integrated into their workflows. And the final conclusion was that the participants felt that the intervention would become a more significant part of their work in the future, with a mean score of 8.1 out of 10. So overall, quite favorable. Oh, sorry. So in terms of assessing implementation, we conducted a document analysis, as I had mentioned before, and this was just collecting materials related to the delivery and receipt of the trial components. So what we found was that all 13 programs created a fully functioning QI team. These QI teams had regular meetings up until the pandemic. They submitted team charters every year, and those team charters had outlined program-specific goals for improvement in each of the 4 areas related to the intervention. Members of the QI teams participated in monthly provincial collaborative calls. And these collaborative calls were occurring quite often. So in 2019, for example, there were 9 collaborative calls with a median attendance of 8 out of 13 programs. Unfortunately, with the onset of the pandemic, in the year 2020, there were only 3 collaborative calls hosted, with a median attendance of 3 out of the 13 programs. We know that the educational materials, for example, Explore Transplant Ontario, they were all distributed as planned, and all the educational materials that were curated were available on the Provider and Patient Resource Hub. What we do know in terms of the performance reports is that CKD programs did not receive the intended number of data reports. So the quarterly performance reports were distributed only 7 times throughout the trial, and the transplant referral eligibility reports were distributed 4 times. And I think this this was an issue with more difficult. The reports were more difficult than we anticipated to create, and we had some data issues early on. In terms of the Transplant Ambassador Program, we know that most programs had a fully functioning Transplant Ambassador Program. In 2018, there were 6 ambassadors, a median of 6 ambassadors per CKD program. It did range from 1 to 9. But the Transplant Ambassador Program was impacted by the pandemic, as there were a less number of ambassadors, and those ambassadors were unable to enter into the hospital. So another component of our assessing the implementation was the fidelity analysis. So this was more of a quantitative analysis of understanding implementation. In the 4 pillars, what we found was that for the QI teams and administrative support, Pre-pandemic, 60% of respondents indicated they always or often attended QIT meetings, but this decreased to 13% during the first wave of the COVID-19 pandemic. In terms of education, we know that 28 to 68% of QIT members used educational resources, and the perceived helpfulness of those resources ranged from 71 to 100%. So those who did use them found them helpful. Outside of the QI team, though, more of like the frontline healthcare professionals, anywhere from 12 to 71% of healthcare professionals used educational resources. But again, those who used them found them to be, or perceived them to be, helpful. So the use of educational resources really did decline during the first wave of the pandemic, with resource use really increasing later, but usage never really returned to pre-pandemic levels. In terms of the performance reports, as I mentioned during the document review, there were only 7 performance reports administered, and of those that were administered, only 4 out of the 7 were reviewed by the QI team leads. So what we found is that 17% of professionals outside of the team, QI team, indicated they reviewed at least one improvement snapshot report. So the QI team only reviewed 4 out of the 7. And then if you were outside of the QI team, you were much less likely to have reviewed at least one of the performance reports. And when asked healthcare professionals on a 5-point Likert scale, they're basically neutral about the ease of interpreting these reports and their perceived usefulness. So the performance reports, as I mentioned, they were difficult to implement, and they required a lot more work and likely need more time to optimize them. In terms of the Transplant Ambassador Program, I presented a little bit in the last slide about how many ambassadors were at each program. But what you can see here is that, from April 2018 to March 2019, there were 1,546 interactions between our transplant ambassadors and patients and families, patients, potential donors, and families. This was sustained from April 2019 to March 2020 with 1,478 interactions. But again, with the onset of the pandemic from April 2020 to March 2021, the interactions fell just down to 150, which was, so the pandemic hugely affected the Transplant Ambassador Program. So in terms of the interviews, again, still understanding the implementation of the ENACT LKD intervention, we developed 5 themes from the interviews. So I'm just going to go through the themes one by one. So the first was that the intervention was highly complex, or was complex. So an example of that complexity was that there are educational toolkits for providers included several types of materials that could be used, and people weren't sure, healthcare professionals weren't sure, which ones to prioritize or how to use each material. So one example quote is that it took me a while to get a sense of what this project was all about. What is it exactly they wanted us to do, and how do I transition? So in terms of next steps, we think about whether we can provide a more focused intervention and more clear instructions. The second theme was unclear roles or responsibilities. So an example of this is, professionals were unsure of which educational materials to use or how to support the Transplant Ambassador Program. An example quote of this was, "Really, in my role, I feel greener than green and not totally sure what my role is." So, from our standpoint, we can probably do some more work in the future to improve role clarity and provide more explicit instructions on how to change workflow. The third theme was a lack of resources. Many of these new initiatives were downloaded to the QI team leads, who were often the program managers. So it was a small group of people who were trying to implement each of the 4 components. And so one example quote was, "Every time another initiative rolls out, there's not a whole lot that is decreased. It's always the same managers." So potentially a small group of people who are taking on several initiatives, at one time. And so in terms of future optimization, we think about additional resources and adding support in terms of personnel or funding to support the transplant work. Theme number 4 was lack of buy-in from frontline staff. So an example of this was that frontline staff may not have enough knowledge about transplant, which potentially hindered buy-in to transplant broadly. So an example quote was, "Some of them felt that we were being too aggressive to sharing the option of living transplant, that we were offering a bias that is the best treatment." And this quote goes on to say that, potentially we should be presenting it in more of like a menu option and not favoring transplant the way we had. And so in terms of what we can do for next steps to address this, in the early onset early in the trial, we had hosted a few collaborative events, which really helped to promote kidney transplant and get people energized about this treatment option being the best treatment option. And as an organization and as a group, we could think about continuing to offer these collaborative events to include frontline staff and really bolster their excitement and enthusiasm and understanding of what our strategy and goal is for our patients. And the last theme from the interviews was opportunities for relationship building. So what came out through the interviews really nicely was that people who participated in the trial really valued the strong relationships that were cultivated, especially in those monthly collaborative calls where they were able to share best practices and kind of new ways of doing their work. So they valued the relationships that they fostered across programs, within their own program, across programs, and then also with their corresponding transplant center. And so we want to continue to foster this new community of practice moving forward. So those were the themes that came from the interviews. So I mentioned that another part of this process evaluation was to try to understand the mechanism of change, or why didn't the intervention work? And we used the theoretical domains framework to compare the perceived barriers and enablers to transplant in intervention group programs and CKD programs. So both groups, all 27 programs, were asked to recall the barriers they experienced that prevented patients from receiving a kidney transplant before and during the trial. And so healthcare professionals in the intervention group and the usual care groups reported that they did not really find each item as a barrier before or during the trial. So they disagreed or felt neutral that each item that we asked was a barrier. And if you recall, we asked items specifically targeted that we thought the intervention components targeted. In the intervention group, there was a slight improvement over time in the mean scores for all the reported barriers, particularly in the pre-trial and post-trial pre-pandemic period, so prior to the pandemic. But in most cases, the responses were very similar. And this suggests that these barriers that we thought we were targeting may not have been a concern from the provider perspective. So limitations to our process evaluation are important to mention. So there was only a subset of staff that responded, and responses really were from the most experienced healthcare professionals in terms of delivering transplant education and performing transplant work. There were 2 out of the 13 programs that didn't respond. And we do know the COVID-19 pandemic really hindered the ability of the QI teams to function, the Transplant Ambassador Program to have in-person interactions. And then also it really created an issue with large staff turnover as staff were really redeployed to other areas, or they actually left their profession altogether or position. When we looked at the barriers, the analysis of barriers, we really only asked healthcare professionals about their perceived barriers. And we also asked them to retrospectively look over a several year period at their barriers. And they are also asked to rate barriers from not only their perspective, but to rate the barriers experienced by others like patients, living donors. So not the optimal methodology for that barriers assessment. So just to say with that, it's possible that some of the barriers that we targeted would have been highlighted as true barriers if a more diverse group of stakeholders were asked in this evaluation. So some interpretations, you know, we really are proud of the QI infrastructure or the quality improvement collaborative that has been created across all 27 programs now, that's dedicated to increasing access to transplant. Everyone in the collaborative is strongly engaged with the intervention, and they do accept this as a new part of their work. We acknowledge that there were implementation challenges, and we do need to integrate some components better into routine care. This means that we might need to simplify some components, provide better training on how to use each of the resources or the components, and then also have a plan for staff turnover or retraining. The fidelity of the data component or the performance reports was low, but we still believe that audit and feedback is evidence-based, and there is room for improvement with the data reports. So I think we do plan on continuing to work or rework these. And then the Transplant Ambassador Program is really a gem that's been born out of this trial. And we are committed to continuing to work with TAP. All of the programs continue to promote interactions with TAP and work with TAP to try and increase the presence throughout patients' transplant journey and throughout the living donor journey. Finally, just to say, it's possible that the barriers we targeted weren't a concern, but just to add, we learned so much throughout the trial with this ongoing collaborative that it is really informing our current work. So an example of this is, you know, we learned about the issue of lack of resources to complete transplant referrals, and coming up, hopefully, will be additional funding now for programs to complete transplant referrals. So out of the learnings of the trial, really we're navigating you know, new improvements that will hopefully improve access to transplant in Ontario. So I just want to say thank you. Dr. Justin Perceau is the implementation scientist at University of Ottawa who helped with this, and Mackenzie Wilson was the research coordinator. Obviously, thank you to a whole ENACT LKD trial team, Ontario Health, which is the Ontario Renal Network, and Trillium Gift of Life, and our transplant ambassadors for being so amazing. I'll take, because we can both take questions.
Yeah, thank you so much, Amit and Seychelle, for those very insightful presentations. Happy to take any questions. I don't see any in the chat so far.
I can ask the first question. Thank you so much, Amit and Seychelle, for such a nice presentation and for coming to speak to us today. If you could add a component to the 4-component strategy, now knowing everything that you know, is there something that you would add or prioritize over one of the other components?
Who's gonna say it? You go, Emmett.
Well, yeah, you've alluded to this. In administration, having more funding for the programs to fully implement things and also to have some resources to support the transplant evaluation completion. That came out of the trial, and that was actually now programs do receive a little bit of funding for that. And Seychelle said there might be more, but that was one of the things we learned.
Thanks. I can ask a second question. With the education components, what do you think that you could do to increase the usage of the educational materials outside of the QI team?
Which audience, Katie?
For providers or patients?
Yeah, providers or both.
I can just say that we learned so much throughout the trial. So a lot of the resources that were curated for the trial are now we just needed to be maybe a little bit more prescriptive about what to use, when to use it, like who to use it with, like that kind of thing. And in fact, now because of what we learned in the trial, we've now created, or we're in the process of creating, a standardized education for providers, which really uses many of the materials that were used in the ENACT LKD trial, but now we're just being a little bit more prescriptive about, like, this is the educational objective, this is the resource you use. So just being a little bit more organized, and it's again, it all came from the trial.
That's good. Thank you so much.
If you don't mind, just outside of my moderator duties today, I am quite deeply involved in leading our transplant ambassador program within our hospitals, within our 26 hospitals, particularly our phase 2 hospitals. And the emphasis on virtual TAP that came out of COVID, and how we really shifted in terms of utilizing virtual conversations in so many ways, but really to match volunteers with a transplant ambassador that may be outside of their geographical region, but can really speak to them individually in terms of where they're at in their experience, and whether that's from an age perspective, gender, culture, language. Within TAP, we've focused on recruiting a really diverse team provincially of transplant ambassadors that can speak to folks really and meet them where they're at based on their individual circumstances. But also, I attend a lot of the quality improvement teams with the QI teams in the hospitals, and the focus from an education perspective, certainly, and I think this alludes to one of our next steps that Dr. Yohanna mentioned, was really implementing TAP education within whatever system they use for new and incoming renal staff, like an LMS or things like that, so that education is ongoing and happens for all of their new staff to help with turnover, so that everybody gets that education. I think that's made a great difference, and also, helped to take some of the burden off, where we have more than one sort of quality improvement champion lead in the hospital, that we have, several that understand the impact of speaking to somebody with lived experience in the TAP program for their patients. So yeah, I know Sue is here. I don't know if she has any comments, or am I putting her on the spot to comment? Sue is the current chair of the TAP program.
No, I don't really have any comments. I mean, I think it was a pretty thorough presentation. We've learned a lot as a team, the whole team, all of us, including Seychelle and Amit and all of the hospitals that we also partner with. And TAPS learned a lot. And I think, we'll just be busy, incorporating those learnings as we go along. But there is another question, Alex. Someone's got their hand up. I think it's Sherry.
Right.
Sherry, please, whenever you're.
Sure, thank you. I really appreciate this presentation. I've actually read all your studies and I'm involved in this community quite a bit on a research level. I've noticed that TAP has expanded beyond Ontario, particularly to the eastern provinces. Just wondering, is there any plans for expanding Explore Transplant Ontario beyond Ontario, as some provinces are really low on resources, while others are a bit more rich? So I guess that's the question.
Maybe like in terms of the Explore Transplant Ontario program, the online doesn't cost too much, like hardly anything, just to have more access. And I think it's open access now. We actually mass produced also Explore Transplant Ontario, so people could take a little card and put it in their computers or have a DVD at that time. And that's actually quite expensive, mass production of educational materials. So you can contact Istvan Mutsi, Dr. Istvan Mutsi at UHN. My understanding is the Explore Transplant Ontario and Seychelle, correct me if I'm wrong, is now open access, so people can access it right now online. Isn't that true?
I think so, but I don't know whether you need like a specific login. Somehow I know during the trial, we monitored all of the like usage as part of our analysis. Like I don't know if that's now just like doesn't require a login. But I agree, contacting Dr. Mutsi would be the way to go.
Perfect, thank you. I know you can access the videos because they've been on your website, so yeah.
On the ORN website, there's a provider hub that has provider materials and a patient hub that has patient materials.
Yeah, and I also see them access available again after the trial is over. I can even see them now. You can access them through the Explore Transplant Ontario website.
I
Other than
found
that, actually,
most people used
delivery.
it. Yeah, sorry, most people used it online anyways. I don't think they use the actual packages as often as they used it online.
Like if you really wanted to deliver it as intended, which is a challenge, it's you have to have some buy-in from local personnel, health professionals. They need to like really understand what the person values and then work through a contemplative framework. Like you don't necessarily go exercise right away, but you buy the running shoes first, and then you kind of then make a step like maybe you go outside. So same kind of thing. You take small, meaningful steps, but you have to first figure out what someone values and how a transplant is going to allow them to do more what they value. Like, do they really value spending time with their children, grandchildren, etc. So like that's a key part of it.
Yeah, absolutely. Well, I don't see any other hands. I know that in the interest of everybody's time, we're a minute past. And so, I just want to thank everybody for the questions and comments, of course, Dr. Garg, Amit, and Seychelle for your presentations. On behalf of CDTRP, I don't know why that's such a mouthful for me. But thank you again for presenting. And if anybody has any questions, please feel free to reach out to Erica. Erica's email is ecroft with a K, EKCROFT at cdtrp.ca. And you will receive an email asking for a survey. So CDTRP would much appreciate it if you responded. Thank you so much, everybody. Enjoy the rest of your day.